Hi, this is Mark Purdue, and you're watching EKG video tutorial 4.0 on AXIS. So in our method of assessing an EKG using a kind of mnemonic checklist, we're using the raised right method, and we've just covered in our video series so far rate and rhythm. We are now moving on to axis. Recall that the vector of a normal cardiac electrical axis has both a top to bottom and a right to left component. The top to bottom components established by the atria depolarizing above down to the ventricles, and the right to left components established by the large, more bulky left ventricle, and as it has more mass, it has more voltage, so it'll take longer for the left ventricle to depolarize, so the last bit of energy noticed is going to be to the left-hand side. A normal frontal axis then is going to look something like this, a vector arrow pointing into that left lower quadrant were we to put a 4-square grid superimposed on this picture. To use an EKG to assess a heart's electrical axis, we need to find two leads that will assess the heart in a way that is parallel with the heart's normal electrical axis. And I try to remember something like the number one axis vector finders are lead 1 and lead AVF. In lead 1, we have a negative lead on the right shoulder, a positive lead on the left shoulder, so it assesses the heart's electrical activity in a way that is parallel with the right to left component. AVF, on the other hand, has the imaginary negative lead somewhere in the middle of the thorax, and the positive lead is on the left hip. Consequently, it assesses the heart's electrical activity in a way that is completely parallel with the heart's top to bottom component. A normal frontal axis, if we look at that on a Cartesian coordinate system, is going to be an axis that falls between negative 30 degrees here and then positive 90 degrees. If we find an axis that is more negative than negative 30 degrees, we will refer to that as left axis deviation. If we have an axis that falls in the plus 90 to 180 area, we will refer to that as right axis deviation. And in the rare cases that we see one that it falls between the negative 90 and the positive 180, we will refer to as extreme right axis deviation. As we look at leads 1 and leads AVF to assess for axis, we will be using what I call the Fonzie method. What we're going to do is we're going to take our left thumb and we're going to look at the QRS complex in lead 1. If that QRS complex is overall net positive, then the left thumb will be pointed upward. If the overall QRS complex in lead AVF is right side up, then the right thumb will be pointed up. If we have two thumbs up, then we have a normal axis. Now you can see in the graphic on the right, the positively deflected QRS complex in lead 1, positive in AVF, and so this is normal. Over here in left axis deviation, you can see that the lead 1 is going to be positively deflected, and then AVF is negative, and so on. Let's see how this works out in an EKG. Now you can see on the left-hand side we have lead 1, and you can see on the right-hand side we have AVF. That matches up perfectly with having our left thumb represent lead 1 and our right thumb represent AVF. Consequently, we will look at lead 1 and our left thumb is going to point up because it is positively deflected, and our right thumb is going to be pointing up because AVF is positively deflected. We have normal axis. We might also say we have two thumbs up or double Fonzies to commemorate the work of the great electrophysiologist Arthur Fonzarelli. Let's look at this 12-lead EKG and assess the axis. We know that the number one axis vector finders are lead 1 and AVF. So first we're going to look at lead 1 and see that lead 1 is definitely overall net positive. Then we're going to look at AVF, and we can see that it is overall net negative. So whichever direction the thumb is pointing up, that defines the deviation. So that if the left thumb is up and the other one's down, it is a left axis problem. If the right thumb is up and the left one is down, then it would be a right axis problem. Here again, we have left thumb up and the right thumb is down, and so we have to ask ourselves, do we have left axis deviation? For left axis deviation, we have one more step. If we suspect that we have left axis deviation because lead 1 is up and AVF is down, then we have to look at lead 2. If lead 2 is overall net negative, then the axis is deviated more than negative 30 degrees, and we have definite left axis deviation. Looking back at our 12-lead EKG, we're looking at lead 2, and yes, we can see that overall it is net negative, and so we do indeed have a left axis deviation. Let's look at this 12-lead EKG for axis. In lead 1, Yeah, we can see that it's overall net negatively deflected, and so we've got a left thumb down. And in AVF, we can see that overall the QRS complex is positively deflected, so we have a right thumb up. And in that case, we're pretty well done with this one. This one is going to be right axis deviation. Why should we care about axis deviation? Well, axis deviation is one of those electrocardiographic findings that is not super sensitive, but sometimes it can provide a subtle clue about some underlying condition. Let's look on the left-hand side here. You can see that the left ventricle in this graphic is enlarged. It has undergone hypertrophy either from very tight aortic stenosis or long-standing high blood pressure. And as that left ventricle hypertrophies and gets bigger and bigger, it creates within it more automatic tissue, and so we have more and more voltage. As mass drives voltage and the heart gets bigger, whatever part gets bigger tends to drag the axis with it, or we might say that axis moves toward hypertrophy. On the right-hand side, we can see in this graphic here, the left ventricular free wall has undergone a large area of infarction. As the left ventricle loses mass, it also will lose voltage. And you can see that the normal vector has been drug over to the right because there is a loss of tissue to help counterbalance into a normal axis position. With this, we might say that the axis moves away from infarction. So here are some possible causes of left axis deviation where you have a positive deflection QRS in lead 1 and a negatively deflected QRS in AVF, and then an overall net negative QRS in lead 2. Left and anterior fascicular block is an important one, and that's why I've underlined it here. If you see left axis deviation, you should go on to look for and diagnose, if it is present, a left anterior fascicular block. We will talk more about left anterior fascicular block when we talk about problems associated with ventricular conduction. But suffice it to say now, if you see left axis deviation, you should look for and diagnose, if it is present, a left anterior fascicular block. Now, the rest of these are not tied together with left axis deviation in a necessary fashion. And by that I mean you do not have to have left axis deviation to have a left bundle or a left ventricular hypertrophy or whatever. Left axis deviation can be just a subtle clue to help support any one of these findings. The same thing could be said about right axis deviation, with one exception. In right ventricular hypertrophy, you have to have a right axis deviation. It's one of the criteria for diagnosing that. So if you were to see right axis deviation, you would definitely want to sniff out the possibility of right ventricular hypertrophy. But there are other things that can be associated with right axis deviation. So one of them that I think is interesting is pulmonary embolus. Working in emergency medicine, if somebody came in and they were short of breath and hypoxic and then had a right axis deviation and other indicators of right ventricular overload, you would be keen to assess for a hemodynamically significant pulmonary embolus. So that does it for frontal axis. We're now moving on to R wave progression, which is kind of a surrogate indicator for horizontal axis. Here you can see the precordial leads, and remember that they are situated on the anterior chest from the peristernal region and then wrap around to the left lateral mid-axillary line. Recall that the negative lead is actually an imaginary negative lead that's posted on the posterior thorax, and so the electrical activity runs out toward the precordial lead, so to speak. With that in mind, we recall that V1 through V6 has a characteristic movement from a small R wave to a large dominant R wave by the time we get to V6. Recall that V1 and V2 are situated to pick up septal depolarization, which generally occurs before the rest of the ventricle. Consequently, in lead V1, we can see that there is a small R wave. We can call that a septal R wave, and then a subsequent S wave. Now, the subsequent S wave in V1 is, of course, the overall net left ventricular cardiac electrical activity, and because the overall vector is moving away from V1, it becomes published as a negative S wave. As we move across the precordium, we can see that the leads are moving toward the heart's electrical axis in that horizontal plane, and so the leads are becoming progressively more upright until we get lead V6. By the time we get to V6, we can see that we have a septal Q wave, and that of course is representing the septal depolarization, but because the vector of that small septal depolarization is moving away from V6, it is published as a small septal Q wave. However, because the bulk of the heart is in the left ventricle, as is the voltage, we're going to see a large dominant R wave by the time we get here. The movement is from small septal R wave to large dominant R wave, and this process is referred to as R wave progression. The graphic on the left helps to display exactly what we were talking about. You can see in panel A, in V1, as the septum depolarizes, you can see a small septal R wave being created. On the other hand side, you can see in lead V6 a small septal Q wave being published as a result of V6 picking up the septal depolarization that's moving away from it. If you move to the right, again, we can see in V1 a large S wave representing the left ventricular free wall depolarization, which is larger in mass, larger in voltage, but because it's moving away from V1, we're going to see this negatively deflected S wave. And then, of course, in V6, which is situated right at the apex of right next to the left ventricle, we're going to see this large dominant R wave. R wave progression then can be a kind of surrogate marker for horizontal axis, but we don't really refer to it in terms of axis. We normally just talk about R wave progression or transition. Remember that in V1 we have the septal R and the large S. In V6 we have the septal Q and the large R. In between there has to be an area of transition where we go from small r to more dominant R from V1 to V6. In a normal patient, this transition occurs in V3 or V4. In V3 or V4, we need to see a lead which is essentially biphasic, a little bit up and a little bit down. When we see this transition, we can be assured that the next lead will display a positive R wave as the R wave progresses. Consequently, if we have an early transition in an R wave, there must be some change in voltage that's creating a dominance early in the anterior leads, and then if it's late, there must be something that's suppressing in the anterior to lateral region that normal voltage that would normally allow for R wave progression. Here we can see in the panel on the left we have a small R wave, and then in V2 we have essentially a biphasic QRS complex, and then by lead 3 we already have a complete R dominance, which we should not see until essentially V5 or V6. This sort of thing could occur, for example, in right ventricular hypertrophy, as we've talked about before. Here we can see in lead 1, it already has a dominant R wave. Here again, R wave progression is going to move towards hypertrophy and then away from infarction. Some potential causes of early R wave progression are going to be things like RVH, posterior MI, right bundle branch block, hypertrophic cardiomyopathy, acute RV dilation, again that might be a pulmonary embolism, and then potentially it could be a normal variant. On the left we see an example of late R wave progression, or sometimes referred to as poor R wave progression. Here you can see we don't have the transition zone until V5, and we do not have R wave dominance until V6. Some potential causes of this could be an anterior myocardial infarction. The transition area from the right side of the heart to the far left lateral side of the heart is going to be the anterior wall. If the anterior wall has been partially or completely destroyed by myocardial infarction, then there is no voltage there to help demonstrate R waves in that transition area. Consequently, we don't have upright R waves until we get to V5. Late R wave progression or poor R wave progression can occur in anterior myocardial infarction, left ventricular hypertrophy, and a variant of normal diminished anterior forces. Next up is EKG video tutorial 5.0 intervals.